Good evening. I don't know how many of you are connected yet, but my name is Dr. David Walsh. We're going to talk this evening about some of the ways of approaching the means of getting and staying pregnant. This webinar is my first, so it's going to be very interesting. It should last, the plan is that it will last a little bit over an hour, and I will take questions and I'll try to answer as many of your questions as I can. If you want to, one way to do that is if you want to simply email me to drdavidwalsh@sims.ie, or indeed you will have a facility on this to send in queries as well. So one way or another we will deal with your questions directly or indirectly. So I presume I'll go ahead. Okay, so look, first of all, I'm going to try and open up my slide presentation. So let me bring up the slides here and then share them with you. Share. So this first slide is just a general description, and I've talked here about 7 steps to succeeding, and this is really an approach. It's not a one-size-fits-all, but it's a systematic way of looking at steps to help anybody achieve a pregnancy and to try and help maintain a pregnancy. Now, the first thing to say is that all of this really depends on somebody's intrinsic fertility and the strength and desire and ability, the genetic ability of those sperm and those eggs to get together, to meet, to grow, to develop, to implant. But there are things that can both make that more or less difficult. Now I need to go on to the next slide. Here we go. So the main components of the 7 steps are a system check. And we all know things in life that are relevant for system checks. So in this case, we're looking at genetics, hidden male factor, structural abnormalities, hormonal type issues relating to the endocrine system and the immune system, metabolic problems, clotting issues, and receptivity. Now I know I've gone through those very fast, but I'm going to go back over each one in turn. So we start off, I suppose, with genetics. Now you'll see on the slide, what I've got here is a movement from the parental genetics of the chromosomes. Each human being has 2 sets of 23 chromosomes plus the sex chromosomes themselves. XY, as you'll see above here, on the male side, and XX being the female. And it brings up actually the point that far from being the fairer sex, females are actually have the full genetic complement, and what makes us male is the absence of the extra leg on the X, which therefore becomes a Y, and that's relevant for maybe not so much in terms of fertility, but certainly it is in terms of other male-female things such as red-green color blindness. So it makes us, in fairness, the fairer of the species in some regard. Parental karyotyping is done conventionally on blood, so both the male and female partners will have a blood test taken, and the chromosomes are then grown out, and then they're actually numbered 1 through to 23, and then the sex chromosomes as well. And if you've got too many or too few of those, that will result in issues to do with unbalanced chromosomal material in the consequent embryo. That is the consequence of the half of the sperm, the 23 sets from the sperm and the 23 sets from the egg. So it's actually quite an unusual cause of problems. The most common abnormality in this regard is a thing called balanced translocation in the parents. And I've got just a brief diagram here looking at how what's happened here, you'll see on the picture, is we should really have at the top 2 reds and 2 blues on each side, but a portion of the chromosomes have swapped over. And then with the change of meiosis, what happens is when Mother Nature doesn't know what the future holds, so she puts this joker's card into every single meiotic division, which is she moves chromosomes around. And by doing so, she creates an uncertainty in how that genetic material is arranged. That can be a good thing or that can be a bad thing. But she knows we cannot factor in the future. So we have to create that genetic uncertainty. And that's what meiosis does. So every single sex cell that a man or a woman produces is not a clone of the parent. And that's really important. In this particular case, however, if portions of the chromosomes have swapped over, have translocated, you can end up either with, as you'll see on the right-hand side here, unbalanced chromosomes, too much genetic material or too little, or on the left-hand side, they actually balance out. And what you tend to find, for example, in somebody with balanced translocation, is that there'll be one child and perhaps 3 or sometimes 4 miscarriages. So it's not a reason for not being able to have a child together, it just makes it much harder. And so the normal ratio of having more live-born children than miscarriages, which most women would have and most couples would have, is reversed. And so this is an important, although it's a relatively rare situation, probably accounts for only 2% of couples who've had 3 or more miscarriages. So it's not very common, but it does happen and something that needs to be considered. If we move on then from the human beings themselves, the male and the female, then you move on to gamete issues, the sperm and the egg that each one of them produces. Now, there are a number of sperm tests that can be checked for, the most conventional of which is a standard semen analysis. You're looking at the count, how well they swim, how many abnormal sperm there are. In addition, you can look at another test I'm going to talk about in a few minutes called sperm DNA fragmentation. And also you can look at what's called sperm fish testing, which is where you look for specific abnormalities in the sperm itself, in the DNA or the chromosomes of the sperm. And if, for example, the sperm are diploid, it usually takes 2 haploid, a haploid egg, which is 23 pairs of the sets of chromosomes, and 23 from the egg to make the new 46 human being. But if the sperm is diploid, it has 46, which then added the 23 of the egg makes too many chromosomes, and that embryo will not be able to implant properly or stay implanted, and that patient will either not be pregnant or will miscarry. So sperm fish testing is a way of looking at the sperm that's been produced by that male partner in the process of evaluation. The next thing we'll move on to then, of course, is the issue of pre-implantation genetic screening or pre-implantation genetic diagnosis. Now, PGD and PGS are pretty much the same thing, except that PGD is looking for something specific like Duchenne's muscular dystrophy or cystic fibrosis or whatever, whereas PGS just is looking at the variant of the genetic capability of the embryo to implant and how it's not so much that it's perfectly normal, but it takes out obvious abnormalities. So if you have a PGS screened embryo that has been given the thumbs up, it doesn't mean it's perfect, but it means it's less imperfect than the ones in which a defined genetic abnormality was found. So PGS in particular is very suitable for a woman in around the age of 40 who's miscarrying a lot, and you can significantly dampen her miscarriage risk if she's presenting chromosomally abnormal or genetically abnormal embryos to the lining rejects them, and that she has a high miscarriage rate. So what happens therefore is if you screen out half, let's say, of those abnormal embryos before they get a chance to implant on the lining, then what happens is you're reducing the miscarriage, and you're probably halving the risk of her miscarrying, which is a hugely important thing for somebody who perhaps has had 3 or more miscarriages. The only problem with PGS, apart from cost, is that it does require you to have lots of embryos so that you've got a pretty high chance of having something that screens normal. So you really do want somebody with a pretty good egg count so that you can get lots of embryos. And the best way of testing for that, as many of you will know, is an AMH to check the egg count. Of course, the other way of looking at it in a non-invasive way, and PGS, one of the problems is that if you sample an embryo and slice off a few cells off the outer shell, which now becomes the afterbirth, you do slightly damage the embryo and reduce its intrinsic chance of becoming a baby. So in future, it may well be that non-invasive testing in utilizing technologies such as time-lapse may well be able to make that a much more feasible proposition where you're not damaging the embryos, and in fact you should be able to do it if it's computerized on basically every embryo that goes through every lab. The other way of looking at it is a non-invasive way of PGS on the problem is that you sample so once we've done the PGS or time-lapse, I think I have a slide related to time-lapse too. This is just a picture of the biopsy taking place, what you'll see on the left-hand side at about 9 o'clock, 10 o'clock is the embryo, what's called the inner cell mass. And then out all around it, you've got an outer shell called the zona pellucida, and then you've the trophectoderm, which is the outer surrounding group of cells just inside that membrane. And that's the trophectoderm, which becomes the placenta and the membranes. And those cells then you can see are being sampled from the 3 o'clock position on this blastocyst. So this is a blastocyst. It's got an inner cell mass, as I say, on the left-hand side, the trophectoderm, and lots of fluid in between the two. So it's called a blastocyst, and that's been sampled. This is time-lapse, and you can see here each individual dish monitors the embryo development. And certainly the benefit of these techniques is to both maximize the chance of identifying a genetically normal embryo and also help explain why a cycle hasn't worked or indeed a miscarriage has happened, if that's the case. Finally, of course, post-implantation, you're into a pregnancy situation, and then you're into prenatal testing. What would have been historically things like amniotic fluid would be sampled, or a sample of tissue from the afterbirth, but more commonly nowadays, fetal blood sampling from the mother's circulation, which is a fantastic development now. Again, reducing the damage or risks to the baby from the testing, because it's only just a peripheral blood sample. So, is there a hidden male factor? Now, I've been a little bit unfair to men here, because by putting in Mr. Homer Simpson on the right-hand side, but the truth of it is, in perhaps half the cases, there are lifestyle issues. So anybody who, like me, has to buy the trousers that are, you know, in the wider end of the trouser rail, or you know, have great affinity to the remote and to all the fantastic series on television, and perhaps a bit of an aversion to exercise and the normal sort of sedentary things, they are reflected in degraded genetic material within the sperm head. And so lifestyle issues, most men, if you check for this fragmentation within the sperm head, you will find that the men are capable of improving it. And it's amazing the power of a test that has your name on it. Because once you obtain that, you can see your name, you can see where the problem lies, and most men are capable of reversing that process. But certainly a significant portion would be lifestyle related, and then there are also men with constitutional issues. I just want to show you an element here on the left-hand side, which is a nomogram, which we created ourselves. These are our own patients going through. And what we did was, we've got a green section on the left, which is basically men with very good sperm. And then the mid-range, and then very abnormal sperm to the right-hand side. So what we found, if you look on the right-hand side, and I don't want to make this too complicated, but in simple terms, IVF treatment versus ICSI treatment. So IVF is basically allowing normal fertilization, natural fertilization to occur, albeit in the laboratory, whereas ICSI is where you physically inject that sperm in. If you think the sperm is quite degraded and it needs to be put into the egg in a better condition to allow the egg better time to process it. And what you see from these figures, that in the patients in the IVF group with low degrees of DNA fragmentation, where the men have very good sperm, less than 13, you get very high pregnancy rates, clinical pregnancy rates, which means a baby heartbeat at 7 weeks of close to 80%. Equally, in men where there is a degree of fragmentation, injecting the sperm directly into the egg helps both the sperm fertilize the egg, but more importantly, provides the egg with a sperm that's less degenerated by the time it gets into the egg. And all success in fertility is related to the egg quality and the ability of the egg to process the sperm and repair the sperm, because that's what eggs do. So if you look, for example, on the second line down in the ICSI category, what you'll see is that there's a much, much higher pregnancy rate, 62% clinical pregnancy rate in the ICSI group compared to the same group below of 47%. It's about a 35, more than a third more likely to result in a baby heartbeat at 7 weeks if you inject that degraded sperm into the egg. Now, the significance of this is some men, you know, they've got degraded DNA because they're over 45 or they're diabetic or they've got poor sperm. But a lot of men, particularly older men, might have a normal count and they think everything's great, but everything isn't great. And this is a hidden male factor which can compromise and is compromising many IVF cycles unbeknownst to the couple. And indeed, even in terms of miscarriage risk, again, the same thing will apply. So if the DNA fragmentation is very elevated, you do need to consider what approach you're going to take. And I've made a list here depending on how significant it is. With a sort of moderate situation, you're going to physically inject the sperm into the egg. With something perhaps more aggressive than that, maybe with a history of miscarriages, and particularly where the man has high amounts of abnormal sperm, you'll be looking at a thing called IMSI, and I have a picture to talk about that. TESI is really just taking where you take sperm directly from the testicle. We don't really do that much, as most of the men are delighted about. And of course, the end argument of the whole thing is, of course, donor sperm in an extremely rare situation where the sample is so bad that you really have to have a genuine conversation with the male as to whether it's worth doing treatment. This is just a picture showing the comparison of when you're viewing sperm, you tap them on the head and suck them up into the tube, which you can see on the right-hand side here, and then push them into the sperm into the egg. But you can see here a conventional ICSI route, ICSI view at about 400 magnification on the left-hand side, same picture on the right. The problem is that you can look at, for example, these bottom two sperm on the bottom right image, and they look very wonky indeed, very abnormal shape, and they've also got these little holes like craters in them, which are markers of genetic abnormality within the sperm head. So you wouldn't really want to touch those with the barge pole. But if you look at the other two, you've got a fantastic sperm on the left-hand side of the bottom image. Really wonderful head, mid-piece and tail, and equally the one on the top right is quite pretty too. But if you look inside the sperm head, it has a vacuole too. And if you've ever had a party in your house and you want to clear everything out of the house, you bag it in plastic bags and put it outside the house to get things back to normal. Well, that's what the cell is doing. It's getting rid of superfluous, unwanted, damaged DNA and pushing it outside the head of the sperm so it can get on with life. Therefore, in a conventional ICSI view, you would not be able to tell the difference between these two, because with the IMSI picture, that's an 8,000 magnification compared to 400 times conventional ICSI on the top slide. So that's the rationale, and the really suitable people for IMSI are patients really with ICSI failure, miscarriages, and particularly high numbers of abnormal sperm. So it's worth looking for the normal ones. Are there structural abnormalities? Well, women, you know, if you ask somebody, well, is your womb normal? They tend to say yes, and then they think, well, why did I say that? Because most of the time, or many of the time, they actually don't know. They assume it is, and most of the time they're right. It probably is normal. But, excuse me, there are some patients who have hidden or not so hidden abnormalities, and I'm going to show you a few of those. The main ones that we look for are things like polyps, which is like a nasal polyp, except it's in the womb, and it can make it more likely that somebody will miscarry. Scarring is a thing called Asherman syndrome, which is quite unusual, and fibroids are small, smooth muscle masses which can sort of push into the cavity, a bit like if you're sitting in a room and one wall starts to sort of move in and occupy that space. And of course the problem is if an embryo tries to implant on any of these things, it's going to have a really difficult time, and therefore the patient is likely to either not get pregnant at all or is going to miscarry. So what you've got there is a normal uterus, etc. I've just put up a range of Müllerian duct abnormalities. These are actually very common, and maybe not to the extent that these images suggest here, but these are soft or mild versions of these are quite common, because the woman's uterus is actually composed of two half uteri which come together, and if you have a failure of fusion of the left and the right, you get these elements of abnormalities. So for example, in the bottom right, you have a bicornuate uterus, so you've got this cavity on one side and it comes all the way down, and then you have a cavity on the other side. And we have patients, in fact, where, excuse me, we've done IVF and put one embryo in each horn, and it's worked for those patients. On the left-hand side of the bottom, that's a bit more common scenario. What you see is the dipping of the cavity of the top wall into the cavity itself. And certainly, over the last 20 years or so, reproductive medicine, which is what we do, and reproductive surgery, which is operating on fibroids and all that, have sort of separated. But in recent years, those specialties, our mutual specialties, have started to come together to complement each other, because there's fairly good evidence that surgery, even to modify mild abnormalities like this, maybe a heart-shaped uterus, which you'll see on the left-hand side, but in the midsection there, called an arcuate uterus or a heart-shaped uterus. Some people have shown that this improves the outcome by even mild surgery to correct and to normalize the cavity. So that's an area that has changed in recent years. Just to show you, it's a horrible picture of a fibroid uterus there on the left-hand side, with fibroids on the outside of the womb and in the wall, and then inside. That would be a terrible picture. But for most people, they may have small fibroids, 1 or 2. Most of the time, they don't cause a problem, but sometimes if they're pushing into the cavity, they will act like a stone in the shoe and need removed. The image below in the center is a polyp in the uterus. And one of the things that's easy to miss is a polyp in the uterus if you don't put fluid into it. It's very easy to do a scan if you don't put contrast media in and actually think, well, it's just a thick lining. So you will pick it up sometimes, but sometimes you'll miss it. And patients are always flummoxed as to how that happened, but it's actually not that difficult. So if you really are planning to have a treatment cycle where perhaps you've had difficulty getting or staying pregnant in the past, you really is worth getting a test done of some sort, like a saline sonography, HSG, hysterosalpingogram, whatever, to just definitively say, yes, this cavity is fine. Now, a cavity which is not fine is the uterine cavity on the right-hand side at the top. And what you've got there is these sort of stalactite, stalagmite scenarios. They should not be there at all. And what's happened there is the top wall and the bottom wall are now stuck together with scarring, really dense scarring. And the true cavity is actually up towards the top on the left-hand side there. So that patient needs serious surgery to slice away those scarring and remove those scarrings and restore the cavity to normal. Reassuringly, it's a very unusual condition to have, actually, although we as gynecologists look for it a lot. Tubal pregnancies, well, tubal abnormalities, I should say. If you've got swollen tubes, you should really have them removed, because they will impede your ability. First of all, if the tubes are damaged, you're at risk either, well, you're likely not to get pregnant, and even if you do have an ectopic pregnancy, which is a danger to you. In terms of if you have a swollen tube in addition, it also, if present, acts like this toxic accumulation of all these horrible white cells and infection and sort of pussy type fluid close by the uterus, does appear to significantly dampen the chance of somebody getting pregnant by whatever means. And therefore, certainly in advance of IVF, we generally would like somebody to have those areas either removed, the swollen tubes removed, or at the very least clipped to prevent that toxic fluid backflowing into the uterus. So that's a serious and significant thing to optimize the outcome. Again, treating damaging conditions like endometriosis, which effectively is backflow of menstrual fluid. That's a bit simplistic. And some people describe endometriosis as a disease of theories, because it has so many theories as to how it comes to pass, we don't really know. But one of the main elements certainly is backflow of menstrual fluid. So it doesn't just come out vaginally, but also goes back into the cavity and spreads around the pelvis and causes things to stick to things. It also gets onto the surface of the ovary and can get inside the ovary, and really does cause damage, progressive damage to the pelvis, scarring, to tubal function, and indeed to getting inside the ovary and damaging eggs. And an intervention surgery to deal with this has been shown in randomized controlled trials and on meta-analyses to improve the outcome. So, endocrine or immune abnormalities. There are a couple of markers. I mean, when miners go down a mine, the oldest thing was they'd bring a canary with them, and if the canary got distressed, they had a problem. Well, there are some equivalent tests which you should look carefully at. And my one allergy in this situation is, do not be told my test was normal. Get the test result yourself and make sure that it actually is, because what's normal for a multi-billion celled organism like a human being is not normal for a poor little 12-cell embryo that's trying to implant an uterus, which needs lots of stuff to create those DNA spirals, like folic acid, B12, both components of the DNA spiral for nuclear material that's each daughter cell, 4 cells, 8 cells, 16, etc., etc. So, for example, you want to know, is your AMH low, which is your egg count. Then moving on to the thyroid gland, you really want to get tight control of your thyroid. because embryos are very sensitive to thyroxine, to the absence or lack of thyroxine during implantation. The real problem with thyroid isn't that, though, because you can give thyroxine for that. It's why is the thyroid stressed? Because if your thyroid's showing degrees of distress or stress at the very least, and is tipping up into the upper range of normal, then you may have underlying immune problems. And often the thyroid, affecting the thyroid into the late 30s and early 40s, is the first manifestation of that. The adrenal glands can also be affected, and the problem with them is that if, for example, the organism, are very stressed and you've got impaired cortisol production from your adrenal gland, it'll shut down sex steroid production. So your egg quality will disimprove, and that's a basis for giving DHEA. And any of you who have problems with egg quality will probably have come across probably the two main interventions with egg quality are antioxidants like coenzyme Q10 and DHEA. So checking sex steroids, DHEA levels, testosterone, cortisol in the early morning. You should have good levels in your system in the early morning because your body produces a boost of them in the morning to get you out of bed and to attack the day, and then they start to slide in the afternoon, and then they go horizontal in the evening along with yourself. So just before we go to the bottom end, are my red cells enlarged? Again, a very sensitive marker for another immune condition called pernicious anemia, commonly missed. I'd say up to 20% of our patients have a slight increase in their red blood cells, either what's called an MCV or an MCH. It's an easy thing to miss, but look for it on a full blood count. Probably even more accurate than checking your B12 levels. And again, a history of pernicious anemia in the family, etc. And speaking of the family, then any sort of immune type problems, and the truth is any immune system can affect any system in the body, not just the adrenal gland, the thyroid, the ovary, but also, so you're looking for maybe a family history of early menopause, thyroid issue, rheumatoid arthritis, ankylosing spondylitis. There's a list as long as your arm. Classically, you might ask about things that are linked to that, like dry eyes, funny rashes, sore joints, that sort of thing. Classically, again, into the sort of late 30s and early 40s in association with an underlying family history. And this is a picture now of your immunity. Now, there's two arrows here. You have two types of approach to protecting yourself, and this is linked to your immune, well, as part of what your immune process is. One is innate, and the other is acquired. The innate one is the one at the bottom, which is the natural killer cell with these markers. And if you can see the CD56 marker just in front of that hollow red arrow, which I'll be mentioning probably later on. And then the upper ones are the B lymphocytes and the T lymphocytes, which are your acquired immunity. So if you're exposed to the Ebola virus, just to take a recent one, your B lymphocytes will produce antibodies to kill the Ebola virus, and your T lymphocytes will produce cells that are specifically targeted at the Ebola virus. Whereas the natural killer cells, part of your innate system, are more just general bouncers looking around the place for foreigners or for people they don't like, and to try and, not in an indiscriminate way, kill those. So they're less fine-tuned. And of course, one of the theses and one of the concerns in pregnancy is that if you have a natural killer cell, as you can see here, attacking a target cell, it may be attacking an embryo, which at the end of the day contains 50% of its genetic material from a foreigner, namely the male. So that's the idea that in a normal pregnancy, you allow blocking, if you like, or suppressing of the male antigens or proteins to allow the pregnancy to establish itself. And of course, that's the reason, of course, that Mother Nature has designed pregnancy to be an immunocompromised state, i.e., that's why you need the flu vaccine or any of those vaccines, because you're specifically and evolutionarily designed to be suppressed, and you're suppressed by the placenta, which produces vast quantities of steroids and makes you immunocompromised, or mildly at the very least during the pregnancy, to prevent you from reacting to the baby. And of course that's great, except you need to get pregnant enough for long enough to allow the pregnancy to do that. And if you have uterine hostility and problems with immunity, what will happen is this reaction the pregnancy doesn't allow itself to become established for long enough that the pregnancy itself will then suppress that activity. So what you've got to do is give bridging treatment to allow the patient long enough to get pregnant enough to allow the pregnancy to suppress that otherwise rejection of non-self of the pregnancy. So the machine we use is an immunoflow cytometer, and we do various tests, but fundamentally it's an expanded version of your full blood count, except we're looking at the lymphocytes. And what you'll see on the top left-hand marker here is the different types of white cells in the body, monocytes, neutrophils. Neutrophils, for example, target bacteria, bacterial infections, and then the lymphocytes, which are the more specific and sophisticated element of the package. And then within each of those, then you pull out the markers that you're interested in, whether that's, like I was saying, CD56 for natural killer cells, or CD4 lymphocytes, or whatever. And this is, I put up here now, it's gobbledygook, I'm sure, for most of you, but this is a patient with a very abnormal pattern. If you look at the top left-hand side, these are all her white cells, and she doesn't have that many actually, but she does have a lot of lymphocytes there. And the other place to look at, if we look over to the right-hand side of the top, we look at her overall immune system. These are our T lymphocytes, and it's what's called the CD4-CD8 ratio. That's actually a bit on the high side. So she's got more CD4 T helper lymphocytes and not enough of the CD8s. So that she's an overactive immune system. This, in fact, is not on peripheral blood. This is actually on endometrial cells. Now, the next thing to say is if we look at the bottom, well, the sort of mid on the left, what we've got here is B lymphocytes. There shouldn't really be B lymphocytes in the endometrium at all. So that's an abnormal finding. But probably the most important of all of these is if the middle section on the right-hand side, you can't really see it, but there's an arrow going up and an arrow going down marked in blue. Now, what the top one is peripheral natural killer cells, and the bottom one is uterine natural killer cells. And the problem is, in the uterus, which this is a uterine blood sample, there shouldn't be any peripheral natural killer cells. So the thesis from Professor Siobhan Queenby et al. And others linked to miscarriage risk is that in a steroid deficiency, what happens is the relative steroid deficiency allows these peripheral NKs to migrate or to accumulate in the uterus where they shouldn't be and supplant the uterine natural killer cells, which should be there, and basically replace one with the other. And that makes a really toxic environment and is closely correlated to miscarriage risk in our own patient population. We've shown this clearly, a very strong association. So this is a highly hostile uterus. Now, I put up there score 10 out of 10, but it was just to give an order of magnitude. There should be all uterines and very few or any peripheral natural killer cells. Your peripheral natural killer cells should be in your periphery and your uterine should be in the uterus. But in this case, one is replacing the other. This is a highly abnormal pattern, and this patient is a serious miscarrier. What do you do about it? Well, the randomized controlled trials, meta-analyses accumulate those trials, and they have shown that even routine use of steroids, and this is in IVF in fairness, showed an improvement in pregnancy rates. So you can imagine the more selective use of them definitely are worthwhile. We haven't, we're now really trying to follow up on other sorts of interventions in addition to steroids, because and I've put a quote in there from Professor Siobhan Queenby from Warwickshire. Certainly we have an excellent scientific justification for steroid treatment to prevent miscarriage. So that's a bit of a no-brainer, to be honest. The real question for us is, and just going back to that slide, what other things do we do? And there's lots of things that have been put forward for use, be that vitamin B6, vitamin D, high-dose omega-3s, intralipids, IVIG, Humira. There's a list as long as you're on. And I think what we like to do now is, because we do our own in-house testing for patients, is not just is make it individual for that patient, not just to suppress the bad cells, but also to crank up the good cells. Metabolic problems. I mean, realistically, these are things linked to polycystic ovaries. Polycystic ovaries, if you've got a real metabolic problem with PCO, you will be more likely to miscarry, irregular periods, the sort of classic PCO things, excess face hair on the face or on the breasts or on the tummy. It tends to be linked with metabolic problems in the family too. So you'll tend to find a history of heart disease, strokes, high triglycerides, high cholesterol, clots, strokes, all that sort of thing. And you can deal with most of these. So for example, I put in lists here, the metabolic syndrome, elevated insulin. You can check a fasting insulin level and give drugs to make the patient more sensitive to insulin. Things like metformin, glucophage, also exercise, anything that makes you more insulin sensitive, including low glycemic index diets. PI1 gene is again linked to clotting and to elevated homocysteine levels. So again, metformin and sometimes blood clotting agents. And finally then, the MTHFR gene is a common Caucasian gene where women don't metabolize folic acid properly, therefore they need more than the standard folic acid. So if somebody says, well, are you on folic? Oh yes, I'm on the 0.4 milligrams. If you're a heterozygote, which means you have one abnormal, or a homozygote, which means you have two, you need high dose folic acid, and probably activated folic acid, because you're not metabolizing folic acid. You think you're doing everything great, but actually the embryo is not getting enough folic acid. So that's an easy thing to check for, and it's an easy thing to take. Clotting. There are lots of tests for clotting. A lot of patients will have had, maybe with miscarriage, a thrombophilia screen, which is factor 2, factor 5, protein S, protein C, various things. In fact, the work from Professor Leslie Regan in St. Mary's has shown clearly that recurrent miscarriage sometimes a very fat clotting profile. And that would be this picture. If you look at it, almost looks like a whale actually, but at the mid-piece of it, it's about 20 minutes into clot formation. This is real-world clotting. So the rate of clotting and how wide and thick the clot gets is associated with increased risk of miscarriage. Again, Mother Nature has created women or modified females to be able to manage childbirth. And one of the problems with childbirth is you bleed after the baby's born. So she's shifted women towards a clotting profile so that they can shut their uterus down and not bleed too much with delivery. The problem is, with that comes an increased risk, risks associated with that clotting tendency, and that would include recurrent miscarriage risks, and also would include, in fact, clots in the leg or the lung during pregnancy, even during the first half of pregnancy, particularly heightened during IVF. So we would have a policy of checking for this in almost all patients and then giving blood thinners. It's a very easy thing to do, and it definitely will improve and reduce the miscarriage risk for somebody who's losing pregnancies where they have a very fat clotting profile. It's called a thromboelastogram, and there's two main companies that produce the machine, Rotem or TEG, and they both are useful tests. So the receptivity of my womb, well, this is just a picture of a little blastocyst trying to nestle into the lining, but there are problems with receptivity. There's a group from Spain which has developed a test, which I'll talk about in a minute. But the principle is, and they found that up to 20% of patients with 2 or more egg donation failures have an abnormal sensitivity to progesterone. So they're either too sensitive or too insensitive to progesterone. And that means that our own theory of when we start progesterone has to be individualized to the patient, not just, as many of you who've had a cycle will know, you're given progesterone on a standard day. So we know now that there are a group of women who don't respond as most women do to progesterone. I'm just showing you here, there are various ways of assessing it. In the simplest of terms, you can do a standard, what's called a H&E stain, which is to look for normal dating, or you can use special hormone-based stains like this cyclin E and P27. And what you're looking for is abnormal responsiveness to those hormonal changes, because it's all based on when the implantation window is. When is the time that it's right for that embryo to come in to try and implant? And if you mismatch that, if you're ready too soon or too late, that will compromise the chances. And then, of course, the next test that follows on from these sort of things is genetic test of yes and no markers for receptivity. So we know some markers tend to be switched on and switched off in order to reject or accommodate the embryo. And therefore, we're into the era of personalized receptivity. The problem at the moment is more, in theory this is a great idea, and in practice too. The problem is it's very expensive at the moment, and I know there are a number of labs, including our own, looking at how to bring those costs down for patients. So the correct identification, and I'm going to read off the slide, of the appropriate window of implantation using these biomarkers minimizes implantation failure by minimizing mistimed embryo transfer and implantation. And this should facilitate the concept of personalized embryo transfer, which sort of makes sense in retrospect, really. You think, well, why would you assume that every woman is the same? Clearly that's not the case, but now we know that's not the case. The next step is proving that knowing that personalized receptivity will improve the outcome of fertility treatment, and that study is ongoing. So, 7 steps to success. Are my genetics okay? I've mentioned most of them there. There are some odds and ends of other things like the FMR gene, etc. But in principle, you're looking at parental genetics, the genetics of the sperm and egg, of the embryo, and then of the baby. Hidden male factor, particularly in a man over 40, smoker, any sort of at-risk factors, even if he's got the greatest sperm the world's ever seen, check his fragmentation, particularly if there's a history of miscarriages. Structural abnormalities, they may not be huge, but even mild structural abnormalities are probably still worth looking at. Endocrine and immune problems are incredibly common in women as they approach, even within a year or two of their 40th birthday. So even if somebody has genetic issues, there may be some allied non-genetic issues at play as well. So those are just as important to exclude. In the end of the day, you need to deal with both genetic and non-genetic issues. Metabolic problems, not so common, tend to be more PCO linked. Clotting issues, very common, not severe ones so much, but it's an easy thing to do something about. And then the receptivity of the womb. And of course, the one thing I didn't put in there, which is the most important probably of the whole lot, is the backdrop to all of this, which is that emotional glue that holds your relationship together. Coping with IVF and fertility, I think, you know, if we had something that we could do for couples, one of the things I think we should do is have a gold star system, like they certainly had in primary school when I was in it. And I think anybody who's been through 1, 2, you know, in terms of miscarriages or fertility treatment, the downside is it's a horrible thing to go through until it works. The only upside you can say is that any couple in particular who can get through a sequence, 1 or more fertility treatments, and come out together, facing that problem together, that's an incredible achievement. And on that basis, you would be calculating that this couple are more likely to succeed than fail. Because without that emotional glue, you cannot succeed because you can't survive long enough. And so then what you're looking for is that that shared problem becomes a shared solution. So I have a couple of questions. Okay, about are all the treatments available at the centre in Cork? The short answer to that is yes. We'll be starting up proper IVF in the new year in January. Overweight is an interesting one. If you want to be very negative, there was a study published about 2 years ago showing that the outcome in terms of getting and staying pregnant with IVF in particular was almost halved by having anything other than a perfect BMI. I think the BMI was over 25. It was quite a low threshold. It's a difficult one. I think if the state is funding my treatment, the state's entitled to say, I'm not going to provide you with that treatment until your BMI is right, you stopped smoking, you're this, you're that, you're the other. I think if some people have weight issues. Rarely, they can't put on weight, and that's a problem too, by the way, but it's a very small minority of women in particular, and men, of course, as well. And I should say, by the way, so much of our attention is focused on the female, but the men are really important in this too. Male age is incredibly important, much more so than we would have realized in years gone past. We've been very focused on the women, and male weight in general, health. The one benefit of the DNA fragmentation test is it's quite a good test of general health. So if you're looking after yourself and you're doing all that stuff right, as long as you don't have a constitutional male problem, your sperm fragmentation will be very good, and it's a great marker of general health. Nobody ever thinks of that when they're doing a semen analysis, but actually it's an accessible cell and you don't have to take a biopsy, so it's pretty good. Unfortunately, we don't have an equivalent test for women. But anyway, to answer your question, being overweight does dampen your chances of getting pregnant and does increase your chances of miscarriage. Having said that, you know, I mean, some of us have difficulty shifting weight. One of the only positive things that I can tell you in that regard is small changes have an enormously big impact. So, for example, if you're away from your perfect BMI and you've never been it, as my father-in-law said since he was 11, then you need to, if you can make small changes, I mean, even a 5% change in weight, optimizing your nutrition will have an enormous effect on your biochemistry. And in principle, I'd rather have somebody who's, let's say, above their BMI coming down at a slow but steady rate than somebody who's close-ish to the ideal BMI but going the wrong direction. So that relative change is very important. It's not just absolute. And I have a lot of sympathy for patients who write on their chart, listen, I don't want anybody to be talking to me about weight or anything else. At the end of the day, if age makes a difference, how many eggs you have makes a difference, your weight makes a difference, there's lots and lots of things that make a difference. So what? You've got to deal with things the best you can, and so do we. After miscarriage, is there an increase in fertility? I think the short answer to that is yes. There used to be amazing statistics, or at least I should say recommendations, based probably more on opinion than on fact, that a woman who miscarried should wait 6 months, 12 months, even up to 2 years before she tries again. All of that is gone, gone, gone. Absolutely, your fertility is seems to be quite enhanced. Personally, I think it's probably, well, one element could be that you've had a steroid boost with your pregnancy itself. The steroid boost has dampened down any hostility, and therefore that you're actually more fertile in the weeks and months that follow that miscarriage. It is important, obviously, to make sure that you know retained products in your womb, and any problems, you certainly should get scanned on that just to make sure, because you can get ongoing infection. If immune problems identified, should steroids and insulin be used together for better results? I suppose that's the short answer. Is probably yes. If in doubt, yes. I mean, there are some patients who don't like steroids and steroids don't like them. So what happens is they can't sleep, they're miserable, they're just agitated, and some people just don't manage with them. One of the benefits of doing in-house testing is that we actually monitor those changes. So even for somebody with, let's say, steroid, doesn't like the steroids, we can give them other things and monitor both before and indeed even during pregnancy to show that the cells that should be suppressing are getting suppressed. But yes, sometimes you would give them alone. We're trying to, I suppose, if you go back over the last decade or so, we've tended in the past maybe to give a sort of a standard response. But now that we're doing so many of the tests ourselves at a lower cost, we're able to repeat the tests, and we do actually charge 50% of the first charge if we do repeat tests to encourage patients. So we want to follow the changes that are taking place as well as the couples themselves. So the answer to that question is yes, you can use them individually, often together, but one of the things we're trying to do is individualize that treatment, and that's what we're focusing on at the moment. Do you agree with the theory that being super fertile causes a problem in miscarriage? Yeah, I think Jan Brosen's work, and I mentioned Siobhan Queanby, have clearly shown that there's something weird going on with patients who get pregnant at the drop of a hat but keep losing them. And the real problem is what to do about it. And I think in a clear case of hyperfecundity, I would actually start a conversation with that group in Warwickshire to look at the best approach. It may still end up being a mix and gathering of the sort of things that we've been discussing, but that would be something I would consider in that very specific and special circumstance, because it probably is a different type from what often happens. I would say the most common profile I see is somebody who's had a baby, then starts losing pregnancies and then can't get pregnant at all. This hyperfecundity is really that somebody just keeps getting pregnant, and I have had a patient once who had 26 miscarriages, one after the other, and so clearly she had that problem. That's a different and very special case. How many recurrent miscarriages should a woman have before seeking treatment? I think that's in the eye of the beholder. The Minister for Health would probably, well, that's not fair on the Minister for Health, but certainly countries and health insurance companies and anybody who's actually funding treatment will probably want to restrict the number of tests and treatments to somebody who's had maybe 3 or more miscarriages. And the conventional theory was that in the United States, for example, you'd be investigated after 2 miscarriages, and in Britain and Ireland, you'd be investigated after 3. And there's large elements of truth in that, but it's health economics at play. And I don't think that's unreasonable. Again, the state's entitled to protect the taxpayers' money, but equally, if you're the person who's had 2 miscarriages and you're paying for your treatment and you're the person at risk of a 3rd, then I don't see why you can't make that decision. You're the person who'll come both to any harm or not, or at risk, if you like, from the drugs or from the cost or from the inconvenience. So if you're prepared to do that, I don't think that's unreasonable. And for my own purposes, if I had 2 miscarriages, I think that's something and I was in a position, I think I would rather have those tests earlier rather than later. The reason is money. It's not anything else. That's the rationale for it. It's pure health economics. I've suffered unexplained infertility for 10 years, lots of IVF, conceived naturally, started thyroxine. I think the problem here isn't the thyroxine. I mean, yes, you want to get your control, your TSH between 1 and 2. I think the problem is why. Why is your thyroid a problem? And that, for me, suggests that there's something going on underneath the radar. And that, I think, is where you need to point your attention. Because if you do so, you'll probably start to find other things that are affected. And on that basis, I'd be looking at the why, and I'd be investigating why. It's not the thyroxine's fault, it's the reason for why is the thyroxine needed. So that's a good pointer to where the problem is. Any dietary recommendations to help? I think diet is really important. We work with Marilyn Glenville, a very well-known nutritionist in the UK, and we work with nutritionists that work for her in Ireland as well as in the UK. And certainly her thesis essentially is based on the premise that intensive farming has leached a lot of essential elements out of the soil and out of the food that we eat, therefore we need to supplement. And I think aggressive or maybe constant supplementation is worthwhile. Things like vitamin D, really important, omega-3s, etc. The testing can be a little bit, variable. It's not clear-cut what the best sort of tests are, although something like vitamin D levels are very consistent. But yes, it is a good idea. Get your supplements, be on the things that make a difference. And you've got to remember, even if it's a marginal issue in terms of, let's say there's a sperm issue or an egg issue, if you can make that individual sperm or egg significantly better within the band of whatever it is, then you are, on the balance of probability, significantly improving the chance that that individual embryo, whenever it gets into the uterus, will have a chance to work. We do have a How to Get Pregnant guide, which is on our website, and you're very welcome to use that. And I think that's most of what I have to say. I've got a final few questions here. Yeah, this is interesting. This is somebody with, remember I was saying about, generally speaking, for every third pregnancy you'd expect a miscarriage. So, you'd expect 2 babies for every 1 miscarriage, as a rule of thumb. But if it's reversed, and let's say in this situation, 1 child with 3 misses, there's something not right there. So you can reasonably account on the grounds of probability with 1 of those misses, and with a bit of unluck, possibly 2, but certainly not 3. So there's something here. Is it genetic, non-genetic? Absolutely 100%. You really, really should. Look for the simple things first. Clotting issues, maybe immune issues. Once you get into genetic problems, it's a bit harder to manage. So perhaps those would be secondary tests. But go for the easy non-genetic causes first. It might be something as simple as taking a blood thinner to reduce that, so 100%. Is there an upper age limit for IVF? We treat patients in their 40s but not in their 50s. Do clinics pass on their files? Yeah, absolutely. You're entitled under the Data Protection Act to information relating to your treatment. So don't get into an arm wrestle between clinics. You just say to your clinic that's there, look, I'd like a copy of my records from my own file, please, yours sincerely. And if you send that letter to them, they are required to send you that stuff, and then you can bounce that on to whomever you want. What could cause repeated very late? See, this is now, there's a big threshold in your mind between a pregnancy loss before 7 weeks and after 7 weeks, before the baby heartbeat and after. And certainly there are different types of investigations. You'd be looking probably more at genetic issues with late miscarriages, and then into structural issues, maybe the neck of the womb is weak, etc. Genetic tests can be carried out, and there's a reference here to cytogenetics, which is the test that's carried out. If the cytogenetics, and this is a genetic test from the baby products that are taken and sent to a genetics laboratory, suggests that they're normal, then I think you have to bounce back, obviously, to non-genetic causes, and you really do need to definitively exclude those other causes that we went through. Just go through those lists. It's not exhaustive, but if you've gone through it in any reasonable way, I think you've probably excluded most of the substantial causes of that. So yes, 100%, I would do that based on a situation where you've had lots of misses, late-ish on, and genetic testing was normal. So I think we'll stop. We've just got 2 more questions. So look, I think the main thing for everybody is, just be proactive, face the challenges together. If you do that, that is more than half the battle. I know this; it's a horrible old process. If a woman has Crohn's disease, and it's under control, could it still point yes is the short answer? I mean, again, we're back to, well, if this Crohn's disease is an inflammatory condition, her, even with control, but you see, it's control related to that multi-billion celled organism, which is the human being. It doesn't mean that at a cellular level, when you've got an embryo trying to get in there, that it's controlled for that embryo. So if there are those toxins going around the system, particularly TNF-alpha and these inflammatory cytokines and chemicals, etc., the cells are distressed, and that will dampen it. So a lot of patients are always concerned, oh, well, my doctor suggested with my disease that I would take a modifying agent like Humira, for example. Take the Humira, because these biologic agents are fantastic. They will turn your immune system off, they'll dampen down the inflammatory process. And the patients, unfortunately, think, oh, well, I won't take the treatment because it might stop me from getting pregnant. If it's things like the new biological agents, these are brilliant. They switch the inflammatory process off. They will heighten your chance of getting pregnant, not reduce it. So the doctors will generally be cautious in this regard, but that's just because they're a relatively new class of drug. But there has been no evidence of any harmful effect in any real sense from patients who actually have had the drugs. So do not be put off having control of your disease, particularly with these new biological agents. It was different in the past, maybe with things like gold or azathioprine and other things, but with the new biologics, they're brilliant. At what percentage motility is IVF? Look, if there's any ifs or buts about motility, don't bother, don't waste your time. Just do ICSI. If you're doing IVF and the eggs are there, inject them. You're not really solving any problems with that. There's an amazing study out from Australia in the last 2 years showing they followed 330,000 children, and they found that first of all, I always thought that when a couple who need ICSI, that if they went out the door before the treatment and got pregnant, hallelujah, everything's great. They didn't need the treatment. Is that not as simple as that? The neonatal death and stillbirth rate was actually higher in patients who conceived naturally who were otherwise ICSI candidates than if they had ICSI. So I've changed my view now in terms of whether ICSI is a good thing. Not only is it a good thing, it actually reduces the risks right down. And in fact, the only group of patients that we treat where we could bring that level right down to normal was ICSI patients with a frozen transfer. So the technology seems to be selecting out those eggs and sperm and reducing those risks. So it's really good news for anybody, man or a couple who need ICSI. Don't worry about it. That era of saying, oh, well, I'll just do IVF because it's more natural. Not only is it not a good idea, it's not a good idea. So that would be a recommendation. So I think that's us. So we're just an hour. So thank you very much indeed. If you have any queries, my email address is drdavidwalsh@sims.ie, and I wish you all every success. Thank you very much.